Yes, we can start.
So, greetings and a warm welcome to all the dignitaries present here. I'm Sravshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching
And
services
warm welcome to all the
exclusively for the doctors.
participants here.
It
I'm
is with
Sravati
great
from
pride
Planet.
that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat. And the focus of today's session is lessons from expert, latest evidence for caffeine citrate in newborns. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, Kunal sir.
Thank you so much, Shriyashi and ClearNet. So, with great pride, we continue with our Neonatal Pathshala series. We had a short break for the Diwali vacation. I wish all Happy New Year. And Today we have a very interesting topic about the latest evidence of caffeine citrate. Kamal sir had taken it during the Guj Neocon, and sir had taken it so well that we requested him to take it again so that it will be on our digital platform YouTube, as well as it will be beneficial to all those who are attending also, and later on also they can visualize see this session to I think Kamal sir is known to everyone, but to introduce to complete the formality, Kamal sir has done his MD from NHL Medical College and fellowship in neonatology from Wadia Children Hospital, Mumbai, and senior registrar from PGMI Chandigarh. Sir is presently working as consultant neonatologist at Kamal Hospital, Maninagar since last 24 years, and he is a very senior neonatologist and known to all. Sir has Limca book record in 2023 for saving the smallest baby, that is as low as 468 gram. Sir is an instructor for NRP, past treasurer for Neocon 2012, and organizing secretary for Guj Neocon 2018 at Ahmedabad, and sir has been faculty for many national and state conferences. Thank you so much, sir, for agreeing and accepting our invitation and enlightening us on such an interesting topic. So, without taking any further, I would request Kamal sir to share his screen and we'll start with the session.
Thank you, Kunal bhai, for a nice introduction. And I will just share. One minute.
Yes, sir.
Share. शेयर काय देतो रे
સર ઝૂમમાં જ નીચે ગ્રીન બટન હશે,
જુમ્મા
શેર કરીને ગ્રીન કલરનું.
ખબર ના પડી
સર ઝૂમ પહેલા ઓપન કરી દો ને, ઝૂમમાં જ નીચે એરો લઈ જશો ને સર, એટલે શેર કરીને આવશે.
હવે
હા, યસ સર.
એ- હમ. Now it is visible.
સર ફૂલ સ્ક્રીન એક કરી નાખજો.
Thank
યસ
you.
સર.
Thank you, Kunal bhai and NF, for giving me the opportunity to speak on this platform. And this is running regularly, and many people are looking at it. So I have tried to justify with most of the evidence which is available. Methylgensins are the most commonly used medication in the preterm infant in the NICU, and it is in use for apnea of prematurity for last 50 years. So it is not new. And caffeine has largely replaced aminophylline and theophylline for the treatment of apnea. And pioneer study of caffeine was done, and it was published in New England Journal of Medicine in 2006. And from then onwards, it has been largely used. And today we will discuss something science related to the apnea of prematurity as well as mechanism of action of caffeine and what are the other uses of caffeine and what are the recent advances has been made for caffeine usage. As you all know, that apnea of prematurity is a cessation of breathing for at least 20 seconds, or if a brief episodes of apnea, which is accompanied by bradycardia, cyanosis, and panic, and which is very common in a premature babies. And 50% of premature baby will have at least one episode of apnea, and almost all infant less than 28 week and less than 1 kg will have apnea during the neonatal period, and their frequency is most prevalent in the first 10 days of life. Apnea, as we all know, can be of three types: central apnea, obstructive apnea, and a mixed type. In a central apnea, there is a complete cessation of breathing, but there is no evidence of obstruction at the nasal passages. While in obstructive apnea, respiratory efforts are present, but there is a obstruction at the nasal or nasopharynx level. And mixed apnea, both the things are present together. What happens whenever there is an apnea in the newborn will have an auto-regulatory mechanism and try to correct that apnea with hyperventilation and by oxygen conservation and reducing the heart rate. But infant without adequate cerebrovascular autoregulation will have a cerebral hypoperfusion leading to a hypoxic ischemic brain damage. So we should try to control apnea as much as possible to reduce the brain injury. So what should be the approach? Whenever there is an apnea, we should try to find out the cause of apnea. And if you do not find the cause, treatable cause like hypoglycemia or a sepsis or a CNS abnormality, then consider it as an apnea of prematurity. And in that, the treatment is mainly of three types. It may be a methyl drug treatment in form of methylxanthines. It may be a continuous positive airway pressure CPAP, or in rare cases, we might need to put the baby on ventilator. Today, we are going to discuss something related to caffeine and theophylline. When we were resident in 1997 to 2000, the main treatment for apnea was theophylline. We used to give it at a dose of 5 mg per kg loading and maintain a dose 1 to 3 mg every 8 hourly. But theophylline has a short half-life, has a narrow therapeutic index, and had a very high toxicity. And many of the babies will have a tachycardia, feeding intolerance, jitteriness, irritability, and sometimes his seizure was also recorded. So, but meantime, later on, the caffeine came as a main treatment. And what are the advantages of caffeine over theophylline? That caffeine stimulates the respiratory center more effectively and penetrates into the CSF more readily than theophylline. It has a wider therapeutic window, so there was less toxicity. Because of long half-life, once daily dose can also be given instead of 3 doses in theophylline. Caffeine also had good enteral absorption, and that's why we can give it orally also, and it has a fewer side effect. Even it was effective in the cases where theophylline was not effective. So caffeine mechanism mainly stimulates the respiratory center, and because whenever there is apnea, there is a immaturity of brain respiratory center which fails to fire impulse to the respiratory muscles. Diaphragm and intercostal muscles don't contract easily, and the baby will have apnea. With caffeine, it stimulates the brain respiratory center, and which fires impulse to the respiratory muscles. Also, it causes diaphragm and intercostal muscle contractions, and the baby will have cessation of apnea. It has both the effect, central effect of respiratory center stimulation, as well as it has a peripheral action of diaphragmatic muscle contractions. And that's why it has a double advantage. The dose is 20 milligram per kg. Loading dose is to be given over 30 minutes, and a maintenance dose is 5 milligram per kg to be given over 5 to 10 minutes daily, once a day. And it's a clear colorless solution which is available, readily available, and we do not need to reconstruct the caffeine. And if you say the baby is 1 kg or 2 kg, like 2 kg baby, the loading dose of 20 milligram per kg comes to 40 milligram. So you have to give a 2 ml IV. If the baby is 1 kg, we have to give 1 ml per kg over 30 minutes. And maintenance dose is 0.25 ml per kg. Right? So if you're a 2 kg child, you have to give 0.5 ml. 1 kg child, we have to give 0.25 ml. And maybe given IV or can be given orally. Once the baby is off IV and baby is stable, we have to give oral. But main thing, how can the caffeine has replaced the theophylline? It was a pioneer study by Barbara Smith, and it was published in New England Journal of Medicine in 2006, which was popularly known as CAP trial, capnia for caffeine for apnea of prematurity, CAP trial. In that CAP trial, uh, in CAP trial, uh, we have basically 4,000 1 minute. હું ફોન કરું સુજલ એક ઇમરજન્સી નું છું મોકલી દો હા મોકલી દો. So it was sorry for interruption. Some emergency was there. It was that there are 5,000 babies, which was from 500 gram to 1.2 kg, were enrolled, and because of some anomalies, 900 babies were excluded, and out of 4,000 infants who were eligible, 2,006 babies were randomized into a caffeine group or a placebo group. So total 2,600 babies were studied in this CAP trial, and the similarity, there were caffeine group or a placebo group, their age, sex, birth weight, gestational age, or mean days of methylxanthine, mean duration of ventilation, their associated problems like pneumothorax, or they were given corticosteroid or not, their IVH grade, everything was studied. And what the outcome was that in caffeine group and in placebo group, death was similar. But the caffeine group babies will remain on mechanical ventilation 7 days less compared to the placebo group. 7 days less duration of mechanical ventilation. And the number of babies who were given oxygen at 36 weeks, at that time BPD criteria was that, and the number of babies who had a BPD was only 36% in caffeine group compared to a 46.9% in a placebo. As well as to other neonatal morbidities like PDA, the number of babies who needed medical or a surgical treatment for PDA was only 29% compared to a 38% in a placebo. And ROP, brain injury, and NEC rate were similar, and other neonatal morbidities were also remained similar. So it concluded, CAP trial concluded that caffeine therapy for apnea of prematurity reduces the rate of bronchopulmonary dysplasia in infant with very low birth weight. So From this study, people started using it. Same study continued, and they long-term effect of caffeine was studied, and they studied the death, cerebral palsy, and cognitive delay at 18 to 20 months in all such these babies. And what the outcome was, very surprisingly, the death was similar in both the group, death or disability total, but cerebral palsy and cognitive delay was very less in a caffeine group compared to a placebo group. So long-term outcome also concluded that caffeine therapy for apnea of prematurity improves the rate of survival without neurodevelopmental disability at 18 to 20 months in infant with VIPW babies. So it reduces the cerebral palsy rate. So to summarize, CREP trial, caffeine was effective in reduces the incidence of bronchopulmonary dysplasia, cerebral palsy, cognitive delay, and this state infant had good mental and psychological development. Cochrane also suggests, review also suggests in 2006 that theophylline and caffeine are equally effective in reducing the apnea in premature babies, but caffeine is preferred because of less side effect. WHO also said that caffeine and aminophylline are useful, but caffeine is preferred if it is available because of its less side effect. And then US FDA approved the caffeine for the treatment of AOP. So caffeine became the preferred treatment of choice for apnea of prematurity. Till 2009, it was not available in India, and then it became available, and from then we are also using it regularly. But even in CAP trial, there was no clear answer of dose, early or late caffeine, prophylactic or therapeutic doses, as well as can be to be given in ventilated babies or on CPAP babies, and till when to continue. And there are other indications like extubation failure or post-operative patient or even bronchiolitis patient. All this answer was not there in CAP trial. So study on caffeine continued, and we will see other studies about the dose and duration of caffeine. See, Skeleton studied in UK, they studied 44 premature infant and high dose of 25 milligram per kg versus 12 milligram per kg. Caffeine was given 24 hours prior to extubation, and what the outcome was? High dose caffeine was significantly reduced in frequency of apnea. So many other studies, we cannot discuss all such, but another study from Egypt, they compared high dose of 40 milligram and maintenance dose of 20 milligram compared to low dose 20 milligram and 10 milligram caffeine citrate in a 120 preterm infants who were less than 32 week old for apnea as well as to prevent extubation failure. And the outcome was high dose caffeine significantly increased the chance of successful extubation and decreases the frequency of apnea. So standard dosing, what was there in CAP trial was loading dose of 20 milligram per kg and maintenance dose of 5 milligram per kg. But all these studies, and even in latest Singapore study, which used 20 milligram per loading and 10 milligram per kg maintenance dose, has also decreased the chances of extubation failure, decreases the frequency of apnea without significant side effect. So we can say that you can start with 20 milligram, but can use 10 milligram maintenance dose if required. But what about very high doses? Before CAP trial, people were using 40 milligram, 80 milligram per kg of caffeine citrate. And whenever you use very high doses, there is increased chance of cerebral hemorrhage, hypertonia, tachycardia, and hyperglycemia. But if you use a standard dosing, you do not require a drug level monitoring. But don't use beyond 40 to 80 milligram per kilo caffeine. Timing to start. In CAP trial, caffeine was used as a treatment of apnea. Looking at short-term and long-term advantages, people started using this prophylactically. So, in Canadian study of 5,000 newborn, less than 31 weeks, prophylactic means less than 2 days of baby were given caffeine, and this shows that there was less incidence of BPD, less PDA treatment required, maybe medical or surgical, and shorter duration of mechanical ventilation, and there is no difference in the mortality. So it also suggests you can use it prophylactically in less than 30 weeks. So what should be the indication? Whenever there is an apnea, you should always try to find out the cause of apnea. Many times you may be dealing with an infection. The child may have a gastroesophageal reflux. Sometimes there may be a metabolic abnormality like hypoglycemia, hypothermia, hypocalcemia. You should try to control this first. And if there is no other attributable cause of apnea, then only consider it as an apnea of prematurity and use caffeine citrate. And in less than 30 weeks, you can use it prophylactically in non-mechanical ventilation. And if the baby is maybe 26 weeker and you know that this baby is likely to remain on ventilator for a couple of days, more than 10 days, you do not start. But if you expect that this baby is likely to get extubated in first 10 days of life, you can use prophylactic. Avoid routine use of caffeine in infant who are likely to remain mechanical ventilated beyond 10 postnatal days. So you can use prophylactically if you expect this baby you likely to get off ventilator in first 7 to 10 days. But what about babies who are more than 30 weeks? We don't start prophylactically. You can administer caffeine if there is an apnea, or if there is apnea persist even after starting a CPAP support. And in all infants, regardless of gestation or postnatal health, consider caffeine prior to an extubation. And same early or late, Patel et al. Study, which was of 144 preterm infant, have demonstrated that early caffeine therapy, initiated within the first 3 days of life, was associated with decreased incidence and composite outcome of death or BPD and PDA treatment compared to all late start of therapy. So duration, till when you should continue? There are no clinical trials to support decision regarding when to stop caffeine therapy. But as apnea of prematurity is not common beyond 34 to 35 weeks, you can continue for 35 weeks. Stop if there is an intubation and expected prolonged duration of mechanical ventilation. You don't need to give it if you are maybe likely to remain on ventilator. And you can stop whenever there is a baby apnea free for 7 to 8 days. Right? But there are certain studies which suggest that when caffeine is continued beyond 35 weeks, maybe up to 40 weeks, they have shown that there is a significant reduction in episodes of intermittent hypoxia in preterm infant compared to standard discontinuation at 34 to 35 weeks. And as you all know, that intermittent hypoxia is a main factor of neurological outcome in preterm babies. So we are tempted to use it up to 40 weeks. But at the end, they said that further studies are required before we recommend it for more than 35 weeks. So at present, you can continue up to 35 weeks, but further studies we may continue up to 40 weeks if the baby had a frequent apneas. Then prevention of extubation failure. CAP trial has not reported the extubation failure rates. Additional adding additional dose of caffeine 1 hour before ventilator weaning, it was said that it was safe, effective, and in preterm infant with IDS. So, should we use additional dose of caffeine 1 hour before the ventilator weaning? There is an emerging multicentric randomized control trial, NeoCough trial, at present is going on. We in NeoCough trial, they give a 20 milligram per kg of caffeine before a planned extubation in less than 32 weeks. And this is the study design that less than 32-weeker babies who are on mechanical ventilator for more than 48 hours and who are planning to extubate and who do not have other asphyxia or other congenital anomalies, they are randomized into two groups. One group will receive a 20 milligram of caffeine 1 hour before the planned extubation, while other group will use a normal regime like 20 milligram per loading and continuous 5 milligram maintenance. No additional dose before extubation. And they have studied and studying the babies at 48 hours after extubation, at discharge, what are the conditions, and at 2 years of age. This NeoCough trial will be available in next 1 to 2 years. Then we will able to tell you that should we use routinely in peri-extubation period additional dose of caffeine or not. Till then, you should continue with standard dose. Then what about the post-operative apneas? Many preterm babies who had frequent apneas in neonatal period who are likely to have surgeries for hernia, hydrocele, or some other anomalies. And if they are likely to have a surgery during post-operative period, they have very high chance of developing apneas, those who have frequent apneas in neonatal period. So certain studies were done, and in that 20 milligram of caffeine was given immediately after anesthesia in preterm babies who had shows that caffeine use was associated with significant reduction of post-operative apnea and breathing. So any preterm babies who had a frequent apneas in neonatal period went for surgery, you should use 1 dose of caffeine during the anesthesia. Then what about the bronchiolitis related apneas? As we all know, the RSV infections are very common in preterm babies who go home. And in first 2 months, if they have bronchiolitis, they are also likely to have a frequent apnea and need a mechanical ventilation also sometimes. When caffeine use was used in such babies who were preterm and present with bronchiolitis, if you give caffeine, there was reduction in the need of mechanical ventilation, right? So it can be useful in patient who present to you with bronchiolitis in first 2 months of life, who are preterm and had frequent apneas in neonatal period. Then what about the multi-organ effect and therapeutic creep? The guidelines are drifting beyond the CAP. People have started using it earlier. People have started using it for broader gestations, variable dosage, and variable duration, because they say that it has multi-organ effect, like the renal protection effect, anti-inflammatory effect, and immunomodulatory effects. So as we all know, that when caffeine was given, these babies had has neuroprotection, has less cerebral palsy, has increased cognition, and increased mental score. As we also know that when the caffeine was given, the caffeine babies will have increased FEV1 at 5 years, and they had a good respiratory score. When caffeine was given, it reduced the PDA and reduced the need for treatment of PDA. So it was useful even for cardiovascular situation. When 4 babies were given caffeine, it reduces the one incidence of AKI. So caffeine reduces the AKI also, improves urinary outcome also. There are also immunomodulatory and anti-inflammatory effect also. and there was no association with anything. So caffeine useful in CVS, CNS, respiratory, renal, and immune system. But before we recommend routinely caffeine for all such indication, further studies are required. So at present, you should continue to use it for apnea, but it has added advantage of other neonatal conditions. So what is should be the recommendation? Use cap standard dose until new safety data emerge. Consider 10 milligram per kg maintenance in selected cases. Avoid very high dose. You should also monitor the babies 5 to 7 days post treatment for apnea recurrence, because once you use caffeine, it has a long plasma half-life, even in the blood for 60 to 70 hours, and the baby will have apnea after 4 or 5 days. So at least monitor 5 to 7 days after you stop the treatment. And routine drug level monitoring is unnecessary as standard. And what should be the take-home message is that caffeine citrate is a first type of treatment for apnea of prematurity with long-term benefit of less BPD, less cerebral palsy, and better cognition. Loading dose is 20 milligram per kg over 30 minutes, and higher maintenance dose may improve the outcome in form of less apneas, reduced need for mechanical ventilation. New trials may refine the timing and dose for peri-extubation period. Before the extubation, additional doses. We should use up to 35 weeks or apnea free for 1 week. And it was also useful in post-operative apneas and even in cases with bronchiolitis. Thank you very much.
Thank you so much, Kamal sir. It was really a wonderful presentation. It was crisp and clear, to the point presentation, and you had covered all the aspects about the caffeine citrate as well as the creep and all those aspects also, that it has effects on other organs also. So it was really a wonderful presentation. If anyone has any questions, they can ask, put it in the chat box, or can unmute themselves also. Uh,
PG residents are sometimes looking at it. No.
yes. Some are there on YouTube also, but there are no questions. Sir, previously doxapram and all those were also used, but I don't think anyone is using it. What is your you do you have any experience of that drug also?
Yes, when I started my practice, there was only drug which was available was theophylline,
Yeah.
and sometimes the baby will not respond to theophylline, and we have to use a doxapram. But it has very high toxicity. Sometimes it will cause even intracranial hemorrhage, and so that's why it is nowadays nobody is using, and caffeine is freely available. But the main disadvantage is the cost. It is little bit costly compared to a theophylline.
Yes. Sir, any difference in IV versus oral caffeine?
Whenever there is an apnea, we usually give IV. But once the baby is off IV fluid and baby on full feed and baby is growing, so as we need to continue it up to 34 to 35 weeks, you usually give oral after we stop IV. And there is no disadvantage, and it has good oral absorption, so you can use it. But if the baby is sick, I think I prefer to start with IV.
And sir, do you continue with caffeine up to 34 weeks in all the babies, or you stop it earlier also?
If some IUGR babies, and if we find that there is no apnea for 7 to 8 days, we may stop early. But most of the preterm babies, if we start around 26, 28 weeks, if we have started, we will continue up to 34 weeks.
Yes. Uh, I think there are no more questions are there. So,
Well, and you people are doing very good job. So you are doing continuously every week. and as well as other neonatal nursing Pathshala, and you are doing good job. I think we should continue such things.
Yeah, thank you so much, sir. And you are a regular participant for our sessions, sir. Thank you so much for joining in those sessions. You regularly ask questions, and thank you so much for sir for that. I think there are no more questions, and we can end this session. Thank
Oh,
you so
thank
much, Kamal, sir.
thank
Yeah.
you, thank you, Abhay. Thank you, NN team.
Shreyashi, you can
Yes,
end
sir.
this session.
Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session today. Thank you. Have a good day to all of you.
Yeah,
Good
have
day,
a good day.
good day,
Good
good
day,
day. Bye.
Shreyashi. Thank you,
Bye.
ClearNet. Bye.